Welcome, Dr. Rachelson. I'm really looking forward to your talk today. So, Dr. Joanna Rachelson was born and raised in beautiful Taos, New Mexico. After high school, she attended the University of San Francisco and received her BA in comparative literature.
Well, thank you, Amanda and Mario, for this opportunity to present for you guys today. This is a topic that I have some experience in, and I'm hoping that with the attendings that we'll be able to have some discussion and see if anybody has any questions, and we'll move through things very briefly and kind of in depth as well. So my topic today is working with the struggling learner. I just wanted to disclose a couple of things. I am not an expert. I have experience in this, but as I'm a new faculty member, I'm definitely growing my depth of experience and have some things I can share, and what things have worked for me and what things have worked in the past and things that have not worked. But I just wanted to disclose that. And then this is purely an introduction. This is a very vast topic and has a lot of things to go into it. So we're just going to focus on basically early introduction and early identification today. And then all of my information is coming from Remediation of the Struggling Learner by Jeanette Guercio, which is a very long book, but it's been very helpful to us and the faculty at the Southern New Mexico Family Residency. So very quick roadmap. I'm going to go through an introduction of what this really is, working with the struggling learner. We're going to talk about what the 6+ is, identifying the issue, and then we're going to see how we can work on generating a plan, and then we'll work through some examples. So, first of all, why is this important? So, learners that have difficulties take up a lot of time. Not only do they take up the time of the advisor as well as the faculty, but they also struggle with some of their own timing issues. And that's something that we'll dive in a little deeper as we progress. But they take a lot of support, and it's important to not ignore them. And it's important to see if we can identify some of the things that they're needing help on. That way we can come up with a cohesive work environment. Ignoring the issue affects not only the morale of the healthcare team, it affects the morale of their peers and their other learners. It's really, you can see it a lot in the when learners struggle with what it does to their peers that work with them. And ignoring that also increases the fact that you don't have a lot of, I guess, like hold with your other learners as well. They kind of can be very rebellious, like, oh, so-and-so gets away with doing this, so why do I have to do it, right? That's a lot of the things that I hear. And so it's very important not to ignore it, so you can identify it, and it helps the program proceed and be successful. And then it affects the program's reputation. Why would people want to go there if there's a lot of people that are struggling that are not being helped? But when people do struggle and they are getting help, then it also helps the program to be like, this person was really not doing very well. The program gave me all these opportunities. I really fixed a lot of things. And now I'm moving on and being successful with my career, because once residents are done, they still have to go on and practice medicine and still have to be very productive in what they're doing. And so we want to make sure that we're not only graduating competent physicians, but we want to make sure that they're confident in all of the aspects, whether it be patient care, whether it be like practice-based learning and improvement. And we'll touch more on that as we go on to it as well. And then deficiencies don't resolve themselves without intervention, right? Nobody can get better if they don't know that they're doing something wrong. So we want to make sure we're still giving them opportunity to improve. And then lack of remediation impacts patient safety and quality care. And that's really the biggest reason why we do things, right? So what do we base this off of? So in 1999, the ACGME standardized the assessments of residents by establishing 6 core competencies that they need to require that are required for them to graduate. The 6 core competencies are medical knowledge, patient care, interpersonal communication and skills, practice-based learning and improvement, and professionalism and system-based practices. The remediation of the struggling learner took those into like one further step, and they called it the 6+. And sorry, that slide is very small with very small lettering. I apologize about that. But they took it and broke it up into a bigger subset. So medical knowledge, clinical skills, clinical reasoning and judgment, time management and organization, interpersonal skills, communication, professionalism, practice-based learning and improvement, and system-based practices, as well as mental well-being. So you can take like the top 4 and put those together into like patient care, and then the other things that go along with that. So what I'm going to do is I'm going to go through these based off of the remediation of the struggling learner and go through what their definitions of each one of these are. And if at any time somebody has a question or wants me to pause and go through something, just let me know and we can do that. But we'll start off with the first one, which is medical knowledge. So medical knowledge is really like they struggle. And we also say that this is the easiest one for us to manage, right? That's why people are here. They're here to grow their medical knowledge, but it's really unable to answer knowledge-based questions. They're lacking of evidence in reading. They score poorly on their written exams. That's how we identify that. The next thing that the next competency would be clinical skills. That's usually seen in direct observation. They're lacking physical exam elements. They're unable to perform things correctly. They have difficulty identifying like what peripheral edema is and if it's pitting or non-pitting and how to classify that, or simple exam maneuvers that they're really struggling with. And then doesn't understand what they're obtaining from their clinical skills. Clinical reasoning and judgment. They have adequate knowledge, and their knowledge base is actually pretty strong, but they lack the fact-based questions. They are using lots of extraneous information in their HMPs. They're unable to focus on their histories and physicals. They order too many tests. They have difficulty assigning like the pre and post-test probabilities. Why is it important for me to do this? What information am I gathering from this? How do I take that information and put it into something where my plan is feasible and it makes sense to what is happening to the problem? That's where they're kind of like lacking in their issues. Time management and organization. They're unprepared. They're disorganized. They really struggle with getting through notes. They really struggle with getting through patients in the clinic. They're shuffling around lots of papers. They didn't write down anything. They're not prepared. There's lots of incomplete tasks, and stuff like that. For interpersonal skills, this is difficulty functioning with a team, right? Their difficulty with interpersonal conflicts. They have difficulties explaining why things are important to them and explaining why is this affecting the team and how they're communicating with their team members isn't going very well. And it also affects them working with patients as well as affects their working with staff. Communication, same thing, very, very similar. They struggle with oral presentations. It can be a language barrier issue. There's poor communication in patient charts, poor communications when trying to recall what's happening in the visit. It appears to have like more patients that are not following their instructions because they're not communicating those instructions clearly, and that kind of thing. So professionalism, which is our 7th core competency, if you will, is poor patient-doctor relationships. Their patients don't really trust them very well because they feel like they're not being respected, or they're trying to be like the cool doctor and not like establishing that boundary very well. They're late, they're absent, they're unreliable, they're dishonest, they can be considered lazy. Those are some of the qualities that come up for professionalism. Practice-based learning and improvement, this one can be kind of difficult. but they don't utilize their quality improvement methods very well. They don't seek feedback, which is a very, I guess, universal thing for learners that are struggling is they, what you don't know doesn't hurt, I guess, is that's the mentality. So they get very defensive for feedback. They don't seek feedback as well. So, and to continue on, systems-based practices. This is more like they don't value input from other specialties. So like for them to see like the hierarchical structure, oh, so-and-so said this, but I don't take that seriously because they're just a PA or they're just a nurse, that kind of thing, which is not necessarily the best thing. And then mental well-being. Mental well-being is kind of hard to classify because it is so broad and it can present in a variety of situations and a variety of presentations. And it's inconsistent, but it shows itself with inconsistent performance. So that's an overview of the 10 core competencies that we're really looking at. So it's the 6+ based off of the 6 core competencies, and then they expanded 4 there. So when working with a learner that is having difficulty, early identification is really, really key. And it's kind of funny because when you have your learner that is having difficulties, things come up that are early, right? You'll get reports like this learner is not doing very well. The chief residents will say something, their staff will say something, other supervising residents or rotations that they've on will start to verbalize like, oh, I think this learner's not doing very well. And then your late identifiers come from your like written exams, your global assessments, and then your rotation failures. But it's really, really important to have those issues and take them seriously so then you can start to work up the learner. And then realizing that there's difficulties and learners struggle at different stages. So when learners first come and they're in that early learner stage, the issues that they tend to have issues with or need more attention to are those medical knowledge things, kind of like going from a medical student to a resident where you're going from that reporter stage into, okay, how do I become a manager and how do I put those things together, which is your clinical reasoning and an integration of data. They struggle with time management and communication. And then we really notice in the earlier years, like their mental well-being. I can't tell you how many times I've had a learner come to me when they first start and they say, well, I'm really tired because I'm not used to like this schedule, right? And I'm not being able to do the things that once brought me joy because I'm not used to this schedule. And so that's kind of difficult for a lot of them to get past. And once they do figure that out, it kind of gets a little bit easier. And then on the flip side, I've had learners say to me, I was so busy in my first year, and now that I'm in my second and in my third year, I have so much more free time that I'm lonely, I'm bored, I don't know what to do with myself, and I'm really struggling with my mental well-being because of the lack of, I guess, busyness, if you will. And then on the other side, advanced learners tend to have issues with professionalism. Clinical judgment and decision making and time management skills. I can't tell you how often we've seen learners who go from their first year where they're seeing very little patients in the clinic to their second year seeing slightly more patients in the clinic to their third year where they're seeing like 12 patients per half day and they're like, I'm so overwhelmed. What do I do with all my notes? I'm getting so far behind. They're putting the staff far behind. That kind of thing is really, really common with the advanced learners. And then their interpersonal skills. I've seen it multiple times as well, where learners who kind of are seen more in the clinic or more in the hospital in a different role because they, for an example, in our clinic, our residents do only 1 half day a week in the clinic when they're first years, and they go from 1 half day a week in the clinic to multiple days in the week and then consistency for their next 2 years. And a lot of their interpersonal communication issues with the staff or interpersonal communication skills with the front or the administration comes out more and more when they're having to be in one setting for longer because it's like, well, I'm busy and I have to rush through things, and they're not giving the time and the space that's needed for the communication to get there. Does anybody have any questions so far? All right. So I wanted to ask, what kind of things have we done to identify learners that have difficulties? And if anybody would like to share or put it in the chat what they have done in their programs to identify learners with difficulties. And I can't see the chat when I'm sharing.
I can read them off if anyone wants to type that in, or you can go ahead and unmute yourself.
Oh. Okay. Well,
I had something. In our program, we had faculty advisors that would meet with the resident, and they could have open conversations about that if they were having difficulties. So I would say maybe either like a self-identifying.
Yeah, that's definitely one that happens, is the self-identification, usually later than we want it to. This is kind of a list from the remediation of the struggling learner as well, where this is kind of like that same thing of like, what kind of things have we used and put in place to identify struggling learners? So direct observation, self-evaluations, presentations on rounds, the 360 evals, which come from like the staff and the learners as well, mini clinical exams, that kind of thing. But really, a lot of it, in my opinion, comes from direct observation. That's usually how we identify learners that struggle the most in the early stages, is direct observation. But it's not until people start putting things in writing are we able to start putting in together plans. So developing plan. Once we've identified that a learner has having issues, we can use a differential diagnosis to narrow down the problem. So for example, and we'll go through some very briefly, some examples of some learners with difficulties, but learner X is showing up late to clinic. They are running consistently behind. They're not getting their tasks done. They're really struggling with putting together differential diagnoses. So I just said that this learner is struggling with time-based management and improvement, systems-based practices, clinical reasoning. What is the bigger issue, right? Is it more that it's a time management issue, or what's going on, and how can we start to scaffold a plan? And it's really important that when a learner is struggling, not to overwhelm the system and try to fix every single problem. It's more important to fix the bigger issue first and then scaffold down to make it more workable, if you will. Kind of like setting a SMART goal, right? If I'm working on something that's got too many things, I won't be able to accomplish or achieve anything. But if I'm working on something that is very realistic, like one issue, like time-based management, or time and management and organization, that's something that is easier to work on than the other 17 things that I just rolled off. And then when we do develop a plan, let's make it a shared mental model and scaffold a plan where we involve the learner, right? If I put together a plan that I'm thinking like, this is what's going to work for me, and I don't take the learner into account, and they come to me and they say, well, you put together all these things that I'm not able to do or unreasonable for me to do, then it's not going to be very helpful for the learner to evolve and grow and get better. And then remembering this is a team sport, and don't try to do it alone. When a learner struggles, it's like I said before, it's very taxing on the system. And we have to do a team-based approach, because one person will die drowning trying to fix one other person. But if we do it as a collective support for the individual, then we tend to do a lot better. So we're going to work on some examples, and I'll probably skip my last example for time reasons. But MQ is a PGY2 resident. His advisor has had multiple complaints about his behavior. His peers have noticed that he does not answer calls in the hospital, and he's always turning off his phone and trying to avoid work. When he was on his surgery rotation, the program director received a complaint that he was not going to his rotation. In clinic, it was noted that he was not following up on tasks and completing and following up with labs for his patients. Does anybody know what this issue is? This is a professionalism issue. This is evident usually later when a resident develops more confidence. Typically, they're usually like second years, when professionalism starts to rear its ugly head, or when it starts to get taken more seriously. We look for evidence of ownership and accountability. So you go and you approach the learner and say, hey, I want to point this out to you. And they say, oh, no, that wasn't me. I didn't do that. Then we really have an issue. These learners are often unable to develop longitudinal continuity with their patients. Their patients will complain a lot, like, I saw this doctor, he didn't follow up on his labs. I saw this doctor, he didn't order my medications. I've gotten lots of things that I needed him to sign, wasn't able to get through them, that kind of thing. And then you also want to pay attention, is the learner taking inappropriate shortcuts? Are they doing things dangerously? Are they trying to use things for time savers? Are they leaving early or being absent often and unreliable? And that kind of things. So that's an example of professionalism. This is an example for time management. Dr. Joseph, the attending physician, has been rounding with his team on inpatient ward services. He notices that the intern coachee always looks very tired, and this has gotten worse over the duration of the month. Another physician remarked that there were orders written by Dr. Kochi as late as 11 p.m. on his non-call days. In fact, that one day he had not been on call prior. He's noticed that his clothes, he was wearing the same clothes, he looked unshaved, and that he needed a shower. When questioned, he admitted that he had not left the prior night and as required by the duty hours. And by the time he had finished his work well after midnight, it did not pay to drive home and come back at 4 a.m. Time management is really hard to work with somebody when they struggle with this, but this is very classic of time management organizations. These learners are often unprepared for deadlines. They don't go to rounds on time. They struggle with getting ready for conferences. They're producing assignments that are late. They're subsequently scheduled patients in clinic. They're often running late. They are often disorganized in appearance. They have pockets that are overflowing with things. They can never find their papers. Their notes are always really lost, and that kind of thing. And then my last example is an example of clinical reasoning. So, HE is a PGY1. HE is sent to the emergency room for a admission for PE. He states, Mr. X is a 60-year-old male with a past medical history of diabetes who presented to the ED for a new onset of pulmonary embolism. He denies cough or shortness of breath. He was recently hospitalized by another hospital and was discharged on Eliquis to treat his pulmonary embolism, and that it was found there. Vitally, he is stable. His SpO2 is 98% on room air. His CT shows another new PE. The resident states that he would like to work him up for clotting disorders. For his new PE, he states that he would like to keep him on his current Eliquis. I know I'm not giving you a ton of information, that the idea is not to focus on the clinical part of it, but the idea is to focus on the fact that the learner is not recognizing that the signs and symptoms are not correlating with the current diagnosis, and inadequate testing or inappropriate testing has led the learner to think of has led the learner to get to a diagnosis without using his clinical skills that he knows to come up with his own diagnosis. And why is it important? And even if it did change the management, he's not actually using his clinical reasoning and judgment to change the management that's currently going on. So that's what clinical reasoning is. All right. So next step, after we have identified the issue, we meet with the learner, we come up with a plan together, we use the learner to develop a team and ask the learner who would be a useful advisor for them and who would be a useful person for the learner to go to if they're having any sort of issues. Implement a plan for frequent check-ins, give realistic expectations and timeframes, and then track the learner's progress. So that means often feedback, also trying to gather feedback or those evaluations from faculty and faculty advisors, and also trying to gather information from other sources such as rotations that they are on, and see if the learner is improving, and giving the faculty, when they work with them, specific things for the learner or specific things to look out for the learner. So if their issue is clinical reasoning and judgment, is the learner able to do an admission from scratch and come up with a differential diagnosis and give the data that's supporting their differential diagnosis, that's leading them from their differential diagnosis to their diagnosis to the treatment plan, and being able to put all that together. If the learner is really struggling with time management skills, what kinds of things have we done to make sure that they're staying on time, right? Is the learner being able to do agenda setting during their appointments so they're only working on 3 or 4 things while they're in the visit, or 2 or 3 things while they're in the visit, because they have to be realistic with the fact that they only have 20-minute visits or so. If the learner is like having difficulty with well-being, what kind of support system does the learner have? What kind of things have they tried in the past, or what things are they trying to do now? But you can't do those things without having a collaboration with the learner, because if we put things into place and the learner doesn't feel like they're helping, then there's no reason for there's no real buy-in for the learner to improve, right? It's like, well, they told me to do this, but that's not going to work for me, so what's the point? I'm going to end up being fired. I also think that the thing that we really need to pay close attention to is when a learner is struggling and they get labeled as a learner that is struggling, what kind of effect does that have on them? They really start to struggle with their mental health and well-being just from that label. And are we giving them enough support? Do they feel safe to come to somebody and say, hey, like, I'm not being supported, or I'm not doing very well. I'm not getting out of the things that I need to, and I'm not able to improve. And so making sure that they're being heard is really important. And then my own thing that I like to say is when a learner struggles, it's really important that you, as the person, as their advisor, has some way of having an outlet from the learner, because you take the brunt of everything that the learner is struggling with. If the learner is struggling with time management, you're getting complaints from the staff. If the learner is struggling from professionalism, you're getting complaints from every single place that professionalism is affected. Is it in the clinic? Is it in the hospital? Is it with their peers? Is it with their colleagues? Is it with the faculty? You're getting so much brunt of the complaints. It can be overwhelming. And so making sure that you as a advisor or the committee has an outlet as well, because it can be very draining to work with a struggling learner. That's it. Does anybody have any questions?
There's a comment in the chat just saying thank you, Dr. Rachelson, from Davina Norris, and also Tracy Groening and Joy Leatherman just said thank you.
Thank you, guys. Thank you so much for taking your time to listen to me ramble on for 35 minutes.
Okay. If there's no more questions, thank you, Dr. Rachelson, so much for being here to present this topic. Just a note to look out for future topics. We'll be doing the fourth Wednesday of the month, a different topic on faculty development. Upcoming topics include resident feedback, forming healing relationships with patients, health equity curriculum, and border health. If you or your faculty identify a topic your program might want or need, feel free to reach out. Also, if you know of yourself or somebody else who wants to present a topic later this year, again, please reach out. But thank you everyone for being here. And next month is March 27th, so hope to see you there.
Thank you.
Thanks, everybody. Have a good day.